knows about it, especially about the central line, but we're gonna start with what's going on here. The arrows doesn't work.
No, just try to click on the screen.
So I'm gonna start with a question. So as the physician leader of your hospital vascular access committee, you are asked to provide a guidance about the use of peripherally inserted central catheters, which is a PICC line in your ICU in the lieu of traditional central venous catheters. So which statement best describes the risks of central line associated bloodstream infections and the risk of DVT associated with these catheters? What's this here? Okay, have to click every time.
I don't know why it's like that.
Okay, so what do you think, guys? Which choice? So I'm gonna. So there's somebody on the group. So let me read it. So at least. So the first choice, PICC line are associated with both a lower risk of CLABSI and lower risk of DVT. PICC line are associated with a similar risk of CLABSI, but a higher risk of DVT. PICC line are associated with a higher risk of CLABSI, but a similar risk of DVT. PICC line are associated with a both higher risk of CLABSI and high risk of DVT. So first year.
Higher or the second option?
Second options. Any other choice?
C or D, that's just based on what I've seen for the second
I
option.
always suggest it's lower risk. I'm not sure. That's why we switch the patient to a PICC line. There's a lower risk.
You go with A.
But I see a lot, you see a lot of DVTs.
Oh, yeah, I see.
What about the risk of infections?
It's also higher.
It's higher. It may be similar or lower.
Raru?
C or D.
For me, both.
So the answer basically B, similar risk with a central line, but high risk of DVT. This is really a recent updates. I think the previous concept, they think this a PICC line is lower risk of infections. But everyone knows that the risk of DVT is higher. But there is like a couple of study being done, meta-analysis, more than 200 study, and they found it's similar risk but higher risk of DVT. Oh my God, this is gonna be okay. So what the objective is going to be today? Define the scope of CLABSI and CAUTI. We're going to review the evidence-based practice shown to prevent healthcare-associated infections. We're going to discuss the strategy to decrease the CLABSI and CAUTI with the inpatient setting and the adherence monitoring and feedback.
Just before we move forward. So yeah, so to me, central line is the same as a PICC line, like in terms of infection, like it's a central access. So it makes sense to me that infection rate is the same. I think the DVT risk, I could be wrong, is higher because PICC line, we just leave it for a little bit longer duration. It's also involves more anatomy than that. Then we keep it for longer. But you mentioned that we take the central line out and put a PICC line just because to me, it's the same. So
I think this it's easy to manipulate even in patients home with a PICC line than the central line has.
Yeah, but in terms of just for IV access, like unless I mean, my approach is I only put PICC lines if patient needs prolonged and antibiotics and to go home on it. If you need a central line in the ICU, at least they go for a central line. When they don't need it, it comes out without a PICC line replacement, right? Not just if, oh, let's take it out, put a PICC line in.
And that's why I think nephrology, they don't like it because the risk of thrombosis and this can cause stenosis, and then it's going to be a problem if you're going to do a fistula down the road. So definitions, there is two definitions. The first one with the National Health Society Network and the CDC, and this is basically clinical diagnosis. The definition of that, they confirm bloodstream infection not related to infection at another site that developed within 2 days of the insertion of central line. So if there is no other source of infection and you have the central line within 2 days, you have the infection's blood culture is positive, then they attribute that to the central line associated. There is another definition. I don't know really practically they do that. I don't think so. We do that too. Then this is by the DSA defined the CLABSI as a colony count of microbes grown from the blood obtained from the central line at least threefold greater than the colony from the peripheral line. To see this is catheter-related infections. So epidemiology, healthcare associated infection associated with high risk of mortality and morbidity and length of stay and hospital cost. We have almost 250,000 bloodstream infections occur almost every year, and mostly related to the intravascular devices, including central lines. So the estimated bloodstream infection mortality estimated between 12 and 25%. Central line associated bloodstream infections account for almost 11% of the healthcare associated infections. Healthcare associated infection, we have the central line like CLABSI, we have the CAUTI, and we have the C. diff, we have the ventilator associated pneumonia, MRSA, and 11% of this associated to the central line. And most cases are preventable by proper aseptic techniques, surveillance, and management strategy. This is just a quick update about the changes. So the last few years before the COVID start, there was really a good decline in the health-associated infections, but they did analysis in 2020, they comparing 2019 and 2012, and they found increasing 47% in CLABSI and mainly in ICU patients, about 65% compared to the world was 16%. CAUTI was increased, but not much. It was 19%, and 30% of them was in ICU. So what's the microbiology related to CLABSI? Data according to 2006 and 7, and they found the most common is gram-positive organisms, especially the coagulase negative staph, which consists of like almost 34%, Enterococcus comes next, 16, and Staph aureus 9.9, and then followed by the gram-negative bacteria. So this is the pathogenesis, almost 3 or 4 way how we get infections in the central line, but the most common is migration from the skin to the exit port of the catheter to the bloodstream and causing the infections. And second, from the healthcare workers, contamination when they manipulate the central line. And the third one, hematogenous, which is very rare as a distant, like patients has pneumonia or UTI or abscess. Risk factor for the CLABSI, the host factor that increase risk of CLABSI, patients who is chronic, has chronic disease like hemodialysis, malignancy, GI tract disorder, immune suppressant state like organ transplant, diabetes can have high risk, malnutrition, total parenteral nutrition, elderly, patient has loss of skin integrity like a burn, and prolonged hospitalization before the line insertion. Also the catheter type, so they found that the single lumen, it's low risk than the multiple lumens. So if you have patients and need a central line, if you think one port is going to be enough, usually they prefer is 1 better than 3 because of the risk of infections. Also, elective versus the emergent, increasing the risk of CLABSI, and then using the full precautions periods versus limited. Femoral line, so a lot of study, and they found the femoral line has a higher risk of CLABSI compared to the internal jugular and subclavian catheters. And they found the lowest one is subclavian, then internal jugular, and then comes after the femoral. There is one study, I'm going to talk about it later, was published by journal, New England Journal of Medicine, and they found really the risk is similar, only it's higher if patients morbidly obese or BMI is high, and then the femoral line is higher risk of infection. Other than that, they found the same, but still all the guideline recommending subclavian, the first, and then the internal jugular, and then if no other option, the femoral line. Other risk factor, total parenteral nutrition and or lipid, and low nurse to patients ratio. So in 2008, they tried to find a solution for that and try to work on that. So they did something called Compendium of Strategy to Prevent Healthcare Associated Infection in Acute Care Hospitals. This really started 2008 and then updated 2014 and then updated in May 2022. So I'm gonna just focus more on 2014 and gonna add some updates on 2022. And this is really done by highly cooperative effort led by multiple organizations like the CDC, American Hospital Association, ID Society. So in 2009, the US Department of Health and Human Services, they did like a action plan to about the CLABSI and CAUTI and like all the health associated infections. And then in 2011, they require all the hospital to report any health associated infections for reimbursement. And then they did analysis after that, almost in 2013, and found the number still high, and almost 1 out of every 25 hospitalized patients, they get health-associated infections. So again, what they did in 2014, they ended with other like some changes, and then they try to have more based evidence. So they did this category, the high, which is grade 1 evidence, and then moderate is 2 and low is 3. And the difference is for the high, they depend on wide range of study with no major limitations, and like a little variation between the study with low confidence and narrow confidence interval. The moderate, it's lower, like a few studies, but few limitations, and some wide like confidence interval, and then the low is just low evidence and weak study. So the prevention guideline they applied in 2014. It's before the line insertion, during the line insertion, and after line insertions. So the recommendation before the line insertion, they recommend to have like easy access to evidence-based list of indication for central venous catheter. So if like ICU, they should have like clear indication for when you have to put a central lines, just to avoid any putting central line that doesn't need to be in place. And then they recommend about like frequent education of the healthcare workers regarding how do you do the central line under aseptic techniques. Also educating the nurses how to manipulate with the central line. And then this was recently bathe ICU patients over 2 months of age with chlorhexidine preparation on daily basis. And I think we've been doing this almost over the last 2 years in our ICUs. So every patient who admitted, they do it every day. And this, they find, this is the study was done, and this is one of the study really was 2021. And they try to compare the daily chlorhexidine bathing in ICU patients and related to the reduction of the CLABSI. And then this study was like over 19 months. The intervention was only for 9 months, and the patient was involved in the study was almost 5,000 patients, and they found reduction in CLABSI in those patients with p-value of 0.01 and confidence interval between 0.2 and 0.8. And this is really one of the like a strong recommendation, like evidence type 1 with the guideline in the central and the reduction of the CLABSI. So prevention during the insertion of the central line, as you know, the hand hygiene, washing hand with the soap and water before and after, or the alcohol-based gels. Even if you're using the sterile gloves, you have to clean your hand before and after. Also strict aseptic technique by using maximum sterile period precautions. Also using 2% chlorhexidine skin preparation for disinfecting skin before insertion. And this is type 1 evidence. Again, avoid the femoral vein as a choice for central line placement on obese, especially in obese patients. They prefer subclavian vein when possible for non-tunneled catheters. And this is really, especially with the new updates in 2022, they're highly recommending subclavian as a first choice. And of course, using under guidance ultrasound, because that is going to decrease the puncture attempt, and that's going to decrease the risk of contamination. And then prevention guideline after insertion, we have to have like daily assessment of the central line to see if need to be removed or not. And what I heard, I think there is a discussion in our ICU to have the checklist for all this like central line, A lines, and catheters to see. That's what I heard this discussion with pharmacy. The checklist to see like when you do like a round, then you have to have somebody have a checklist like central line being like 3 days, and then to see evaluate every day if that needs to be removed or not, just to have like a form of that.
But yeah,
that's what they say discussing to have one.
Yeah,
which is
it's just talk about DVD prophylaxis, all these other stuff that are important too. So, but these are things that we should talk about every day regardless, But the checklist just helps us to remember. Okay, let's do the checklist.
Checklist in the beginning as well when you do the procedure and nurse checks points, everything.
Could be run by the nurses and even the resident. And then replace central line placing during emergency as soon as possible, or at least within 2 days from the insertion. Frequent surveillance in ICU to see the risk of what's the trend for the health-associated infections. Follow recommended central line maintenance practice, and ensure that we have appropriate nurse to patients ratio. Also, this is all like for the nurses, disinfect the catheter hub, injector ports, and connection before assessing the line. Replace the administration sets other than the sets used for lipid and blood every 4 days. 4 days, but now I think they extended to 7 days. Changing transparent dressing and perform site care with the chlorhexidine-based antiseptic every 5 to 7 days, or enter immediately if the dressing being loose or damp. And again, just washing the hand before and after every time they manipulate with the central line. Again, this is the same hand hygiene and septic technique before and after insertion of the central line and during the manipulation. This is a study was done in 2002 about the using chlorhexidine compared to povidone iodine solution. Almost 4,000 patients was involved in this study, and they found reduction in the catheter-related bloodstream infection by 49%. And that's what they're really using here too. Then site selection, as I mentioned, using subclavian unless medically contraindicated, and which was what the things that's contraindicated, either deformity or patients has a chronic renal disease and may require dialysis. And this is like in 2000 National Kidney Foundation, they recommend against using subclavian vein in those patients because of the risk subclavian stenosis. Again, using single lumen unless multiple lumens are absolutely necessary to decrease the risk of infections. This is just quick about the type of catheter, peripheral venous catheters. The risk of phlebitis with the prolonged is very, and the infection is very rare. And then A-line, the risk is low too. And then the midline catheters, and the midline catheter is kind of like peripheral, doesn't go to the central veins, and the risk of infections is low too. And then comes to the non-tunneled central venous catheters, like a central line, and this is the majority of the infection comes from these lines. The same for the pulmonary artery catheters, and then the PICC line. That's why this is they say the lower rate of infection, that's really before the concept that the risk of infection with the PICC line is lower than the central line. But according to the meta-analysis that I mentioned, it's most similar risk between the PICC line and the central lines. And then the tunnel central venous catheters, really there is no study prefer like a subclavian or internal jugular or femoral, and there is no really clear recommendation on that. This is even under the guideline, they said if you think line is the peripheral access being like gonna be more than 6 days, they prefer to have a midline or a PICC line. Make sure you evaluate on the central line daily if there is any sign of redness or oozing or any infections there. And then the ultrasound use. This is the study that I mentioned was published in 2008 in New England Journal of Medicine. They comparing the femoral with the jugular, internal jugular and subclavian. It's randomized multicenter parallel group trial in ICU patients. And what they found in this study, the colonization, it's more in jugular vein than the femoral, but for the risk of infection, it's the same comparing the femoral line and the internal jugular line. But still, with the other study and other guideline, they still recommending subclavian, internal jugular, and the femoral. And this is the same that I mentioned. Maximal barriers required for the central venous catheter insertion using face mask, cap, and sterile gloves. Instruct anyone assisting you to wear the same barriers and cover the patient entirely with a large sterile drape. And this is some study was done in one in 1990 and then the RAD study in 1994. And this study, they try to compare like full drape with limited one with a small drape only and sterile gloves, and they found the risk is 6.3 times higher in the small drape group comparing to the full drape. This is what we call sutureless securement device. So when you put a central line, you don't have to do a stitch. And they found really a reduction in the infections in those patients. I found this study, it was published in 2002 and was for the PIC line, and the risk of infections average. First of all, the time was less in this. When you do this stat lock rather than the suture, and also risk of infection was lower in this group, 2 versus 10 with a p-value of 0.03. But I don't know if we have it here or not. This is that what we have like this one.
Oh, never mind. No.
Yeah.
They've been giving me just like super glue and they're like, don't do anything else and just put this new antiseptic.
Oh, that's that's extra with the suture.
that's
The
extra.
group, yeah,
But that's for the PIC line, so
no,
not
even
for
on the central line. Yeah, I found even for the central lines. And was in 2014 guideline too with this. But they didn't mention anything about it in 2022. Post-insertion antimicrobial ointment and don't reduce the incidence of CLABSI. Sterile dressing should be applied to the insertion site before the sterile periods are removed. Transparent dressing are preferred to allow visualization of the site. And then if there is any losing in the dressing or soiling, you have to change it. Replacing central lines, line should not be removed should be removed as soon as possible if there is no indications. Routine central venous catheter guide wire exchange or site rotation is not recommended. Guide wire exchange is acceptable only if the like malfunctioning catheter or downsizing from the pulmonary artery catheter to the central venous catheter. And of course, patient has CLABSI. There is no rule to do a guide wire exchange. Have to remove the line. And then, so this is the quick updates in May 2022. Again, they pushing for using subclavian vein as a first choice, unless there is a contraindications. Also, the use of chlorhexidine containing dressing now is essential practice and type 1 evidence. And routine replacement of administration sets not used for blood or blood products, so liquid formulation can be extended for interval of 7 days, and that's the one was in 2014. Every 4 days you have to change. Then we're going to talk about the catheter associated urinary tract infections. Account for almost 75% of all hospital associated UTI, and this is data from the CDC in 2019. complication that associated with catheter-associated UTI, increased length of stay of 2 to 4 days, patient discomfort, increase the healthcare cost, and increase mortality. Total US cost per year for the CAUTI is 340 million to 450 millions. So since October 2008, and this is only that's the first health-associated infection was no longer get any reimbursement from the Medicare, Medicaid in 2008. So between 15 and 25% of hospitalized patients, they find they receive urinary catheter during hospital stay. And the most important risk factor, the prolonged use of the urinary catheter. The risk of bacteriuria with the catheterization increased by 3 to 10% every day and 100% by the day of 30. Etiology, it comes from colonic and perennial source contamination and contamination from the healthcare workers. Pathogen is the most common E. coli and form like 24%, and then comes with next with the Pseudomonas and Klebsiella pneumonia. And this is just the good resources for the evidence-based CAUTI preventions comes from the Society of Healthcare Epidemiology of American, IDSA, and the CDC. So the prevention practices use the catheter when only appropriately indicated, use antiseptic technique for insertion and maintenance, hand hygiene, ensure like a properly trained person insert and maintain, use closed drainage system and maintain unobscured urine flow, leave in place as long as needed, and implement improvement program to achieve the appropriate use in ICU, like frequent education and surveillance. This is like indications when you have to put indwelling urinary catheter, perioperative use for selected surgical procedure like urologic surgery. If you need like a strict isonose, especially in the first like 1 or 2 days after admission, management of acute urinary tract retention and obstructions, or patient has unhealing ulcer or skin graft, and you concern about any urinary incontinence and contamination, and if patient's comfort care just for just comfort for the patients. Aseptic technique, hand hygiene before and after insertion, sterile gloves and drape, and aseptic solution before the insertion of the catheter. It's the same. So it's important to train the healthcare workers, family members, or the patient if appropriate. If patient using a chronic indwelling catheter, you have to have periodic in-service training regarding techniques and procedures for urinary catheter insertion, maintenance, and removal. Education about the CAUTI and complications, and have to have frequent feedback for the healthcare workers. So this is like one of the recommendations to implement quality improvement programs in ICU to assure that you have a proper utilization of catheters, to identify and remove catheters that are no longer needed. So you have to have a checklist, daily assessment if you need the catheter or not, and you have to consider alternative like intermittent catheterization or use external catheters, and to ensure adherence to hand hygiene and proper care of catheters. This is just an example with called Keystone Bladder Bundle Initiative, was implemented in 2007 in Michigan, and this consists of daily reminder sheet for urinary catheter use and removal, alternative to indwelling urinary catheters, using frequent bladder ultrasound monitoring and insertion care and maintenance. And they did a study after they implement this program and comparing, they started in Michigan and then they use it in other states. And then they did this study to see if there is any reductions of the incidence of the catheter-associated infections. And they found the Michigan states more strict to this bundle comparing to other states, and the risk of CAUTI was less comparing to other states. This is the same. That's then Michigan decreases by 25% in 2009 and 10, and was 6% other states. And they think this is all just because they strict with this bundle with a good outcome. This is not recommended practices and no evidence. Routinely changing catheters or drainage bags, routine screening for catheterization for asymptomatic bacteriuria, routine irrigation of the bladder with antimicrobials. Unless obstruction is anticipated, bladder irrigation is not recommended. Don't clean periurethral area with antiseptic to prevent catheter associated while the catheter in place. Changing and dwelling catheters or drainage bags at a routine fixed interval not recommended to, and using routine antimicrobial prophylaxis. This is then this is the last just questions here. 8 days after beginning the IV ertapenem through the peripheral inserted central catheters for bacteremic pyelonephritis secondary to extended spectrum beta-lactamase producing Klebsiella pneumonia. A 27-year-old woman is admitted to the ICU. The fever and progressive shortness of breath. At the time of presentation, she has temperature of 38.4 and blood pressure of 84/62, but no evidence of new murmur. Lab white blood cell of 14.7 with a 92% of neutrophils. 2 sets of blood culture drawn at the time of admission are subsequently positive for coagulase negative staphylococcus, which is identified as Staphylococcus. Which of the following statement is most correct about the interpretation of this organism in the present clinical context? A, it most likely is related to urinary tract source or bacteremia, and the patient should be managed as having a urosepsis. It is classic coagulase negative staphylococcus associated with contaminated blood cultures and should not distract from the more likely cause of this patient's clinical illness. The patient has line associated with bacteremia and should be managed with the removal of the PICC line and treated for additional 5 to 7 days of antibiotic. And the last, in addition to antibiotic and catheter removal, the patient should have transesophageal echo and more prolonged course of antibiotic. Need to go back to the question.
Either C or D.
What's that?
D.
D?
No murmur, right? There is no murmur. Just only one time blood culture. It's not repeated blood culture.
Is there an option that says repeat that?
But no evidence of a new murmur. Yeah, but I mean, saying like it's persistent bacteremia. You think about
She has 8 days after she has
Can you go back to the option?
line.
Or and 27 days of antibiotics is probably not long enough, so I don't know how those two here.
Is every bacteremia you have to treat it for 2 weeks?
Not every bacteria.
Mhm.
Well,
But
first
this
off, for gram
organism-
negative.
The organism is a real one, expired, so
Yeah.
we have
Yeah.
to treat it.
Okay.
Yeah.
It has to be treated as a staff infection.
Mhm.
Right.
Exactly. Yeah,
No,
but
even
is
if
it
it is
duration
simple.
wise?
Even if it is simple, if it is not complicated, it needs 2 weeks.
And
If it is complicated, other risk factors like IV drug use and other things, it might go even up to 6 weeks. So I would say D is the
most
better
likely,
choice.
All agree?
D.
Go with D. I'll go with D.
D. Yeah, so the D is the correct answer, and because they consider this bacteria behaving as MRSA. So whatever you do with the MRSA, the same you do for this one. So with this one, you have to exclude that patient has infected endocarditis and the need for prolonged antibiotic.
That's specifically that one,
this one.
whatever.
Yes, this one, yes. But if not, then you don't have to do transesophageal echo, and you have just, I don't know if for coagulase negative staff or uncomplicated related to central line to do antibiotic more than 7 days. First choice, usually this is not the common coagulase staff negative organism causing, and usually with the subprophyticus. And second, a choice, they think this is contamination, and we say this is like behave like MRSA, and you have to treat it. And then C, as I mentioned, if this is not complicated and you think this is all related to the line, then you have to remove the line and treat it for at least 7 days.
This is because it's a coag negative. When you're like coag negative, you think, okay, it could be
Skin, yeah.
contamination of skin. But this one
Okay.
specifically, it can.
Questions?
Did you run across anything? So St. Mary's recently, it's been very hard to get them to allow a catheter, like a urinary catheter. Like I had a patient on a LASIK strip and getting IV albumin, horrible heart failure, and they just would take it out. And I would tell them to put it back in, and they would refuse. And so I don't know if there's like something new at St. Mary's. Obviously there is, but they were telling us that we should just straight cath the patient every hour.
Because
And
they
to
are
me, that seems like
More
don't think
work,
also
more risk
fairly high
protection, I
risk.
guess.
So they are
Yeah.
working on that because all infection related to this, they're not going to get any reimbursement. So they try to avoid it as much as they can. But if you have clear indications,
Yeah.
then there is no doubt. You
Yeah,
have to
yeah.
Apparently, LASIK
Or-
strip is not.
And then you can't-
But you have to remember that a patient who is intubated, even if they're not on even if they're on presses, things like that, doesn't mean you have to have a, that people say, okay, that's automatic Foley catheter, but it's not. It's really if you're following urine outputs, hour by hour kind of LASIK strip situation, you're actively diuresing them. And sometimes you diurese them for a day or two, and then you kind of, stop maybe, or not be as aggressive, but that means you can take the Foley out. So very low threshold to take that Foley out. Like I said, being critically ill only is not really an indication. And now they give you perspective, I don't know, but straight cathing per hour does not really make sense to me, no, it doesn't make sense for nursing work.
Even if you 6 hours.
Yeah,
I think
That doesn't make sense.
And that's what they
But,
want. They involve that with the ultrasound to see. You don't have to do a schedule cath, like straight cath. You have to do it like ultrasound. If there is any significant, then you have to do this intermittent catheterization.
Yeah, that's I guess it depends, but if you really need it, so if you only need it Foley, if you're measuring hourly by hour, if you're not following it, am I looking at this every hour? Am I coming back 5 hours later to check what urine output is? Then the answer is yes, then you may benefit from a Foley, and you can put a Foley for a day or two and remove it once you that you don't need to. But if you're checking a 24-hour urine, you can go stay away from it. Like, there's the Purec for female, there's the condom catheter, though people say
Yes.
condom catheter maybe can be
External
equal
catheter
to
recommended too.
Foley, but there's other ways to measure urine output. The Foley will help you in measuring an hourly by hour reading. If you, like I said, if you have a Foley in, but you're not checking urine output until tomorrow, you don't need it. If you're gonna check it, with night shift only, you may not need it. But if you're gonna check it in the morning and then come back 2-3 hours later, give LASIK and see what their output is and decide, then you may benefit from it, So it all depends on your indication.
Is there any like evidence that you ran across during this that said, frequent straight casts is associated with just as high or similar?
I
or was
couldn't
there
really.
anything
That's
like
a good
that?
question. I will look more and see if there is any study like comparing like the indwelling catheter with the straight catheter. But as one of the bundles that recommend, one of the choices they recommend that if they can do the intermittent catheterization.
Okay.
But the main, keeping sterile and everything is important, but the main risk factor is duration, right? So
Yes.
that's the
Makes
main
sense.
risk factor. You even, if you don't need it, you remove it. You talk about it every day. Patient who was on pressors, even they're still intubated, they don't need that line. You can technically remove it. A line is the same thing, though much lower risk for infection. But at the moment, you don't need it. Like I said, even an intubated patient, they don't really need a central line all the time. So they may need it for a day or two. I know it's a lot of work to put one in and 2 hours, 2 days later remove it. But that's the main concept. And that's where there's a discussion about quality improvement, where we're having this checklist, which we should technically do every day, but we forget there's a lot going on. So if you have this checklist, just like run it after every patient. So we kind of touch base on everyone. Okay, this patient has these lines. Can we remove some of them? Do we need them? And move on, things like that. So, but it's very important to remove them, or not or talk about them at least every day. And sorry, so they keep talking about subclavians should be the first line. Because there's a study, I think it was New England, but there's a study that looked into all these lines, and they found that, as Karem was saying, that if I remember correctly, IJs and femoral line, no risk, higher risk in femoral compared to IJs, except maybe in a subset of patients. But definitely subclavian had a little bit less, not risk of infection, but higher risk of complications. Yeah. There was a high risk of complications. So but subclavian definitely had the lower risk of infection compared to all of them. That's why they keep saying let's try to do subclavian first. But I've seen a lot of complications of that. But if you're comfortable with it, that's where you go to. I think a lot of them kind of do it blindly, but now you can use central ultrasound. It's a little bit technically challenging just because of the clavicle being there. But if you're knowing what you're looking for, you can do a subclavian ultrasound guided, but definitely high risk of complication, both pneumothorax and also bleeding and hematomas. Because I've seen those, with multiple pokes and things like that. So
Thank you.
Yeah. I didn't get a USB. Is that yours?
This is
Oh, so you already transferred.
So-
Is it trans-